Good afternoon, everyone. I'm Dr. Jayasree. I'm a neurologist at KIMS Hospital, Secunderabad. And she's Dr. Shanmukhi, a clinical psychologist at KIMS Secunderabad. Today, we are discussing about memory loss and dementia, clinical and psychosocial aspects. Our aim of today's discussion is to create awareness about these disorders and also to clarify the myths and misconceptions about these disorders which are there in general population.
Thank you, Dr. Jayasree. We are thanks for the warm welcome and introduction. Now we'll go on with the question and answer session. And let's first understand how dementia is. And Dr. Jayasree, can you please explain about memory loss and difference between dementia and memory loss?
Yes. Dr. Shanmukhi, memory loss is a very common symptom with which patients usually come to the neurology OPD. Memory loss can be seen in a number of disorders, very simple disorders also like vitamin B12 deficiency, thyroid disorders, electrolyte imbalances, and diseases of the brain infections like meningitis, encephalitis, brain strokes, and brain tumors, and other conditions like autoimmune encephalitis, such as all these simple disorders also can present as memory disturbance. We see young patients between 30 to 50 years of age also coming to the OP with the complaints of memory loss, memory disturbances, and they assume that they have dementia and they fear whether they developed Alzheimer's disease, whether it is early Alzheimer's. So most of these patients needs good evaluation, and most of these patients have minor issues like vitamin deficiencies, especially vitamin B12, thyroid disorders, which are very common these days, hypothyroidism, and some electrolyte disturbances. Also, these days stress levels are more and sleep disorders, patients with excessive stress, multitasking, and sleep disturbances. Also, they can also experience memory disturbances. So, all these patients need good evaluation, and they need to be aware that all these memory disturbances are not dementia. Okay, now coming to dementia. Dementia is a syndrome characterized by progressive decline in cognitive function. Cognitive decline involving domains like memory, learning, executive function, visuospatial function, and social cognition, complex attention. All these domains, they get affected. And the decline should be severe enough to interfere with activities of daily living. So if they satisfy these criteria, then only a patient can be labeled as having dementia.
Now, after we understand what is dementia, can you explain the types of dementia?
Yes. The most common cause of neurodegenerative dementia is Alzheimer's disease. Again, there are a number of varieties of dementias. Not all dementias are Alzheimer's. So, after Alzheimer's, the other common degenerative dementias include frontotemporal dementia, dementia with Lewy body disease, Parkinson's disease dementia. And other rare dementias include corticobasal degeneration, MSA, PSP, and Huntington's disease. There is an entity called non-degenerative dementia, in which, if properly diagnosed and treated, the progression can be reversed or it can be at least halted. So, one most common cause of non-degenerative dementia is vascular dementia. And other common causes of non-neurodegenerative dementias include alcohol-induced dementia, normal pressure hydrocephalus, subdural hematoma, and traumatic encephalopathy, and HIV-associated dementia. These conditions need to be identified and properly evaluated.
Can you also explain the mimics of dementia, please?
Yes. There are a few conditions which mimic like a dementia. So one most important condition is delirium. Delirium is a condition in which a patient has fluctuations in the level of consciousness. So they lack attention and concentration. And common causes of delirium include metabolic disturbances, especially hepatic encephalopathies, uremic encephalopathies, and electrolyte imbalances like sodium hyponatremia or hypernatremia, and even alcohol intoxication or alcohol withdrawal can cause delirium, and also drug intoxications and substance abuse, drug abuse. All these conditions can cause delirium, and that needs to be properly evaluated and identified. And one other mimic is depression. Depression. In depression, patients usually they complain more about memory disturbances, but they have very poor effort on cognitive testing. They show very decreased interest in doing the test, in performing the test. So their effort is very less, and they say they don't want to do. And if at all, if they cooperate, the cognitive assessment will be usually normal in these patients. And recently, there is one more entity called minor cognitive impairment, that is MCI. This is a condition which is a condition which is a state between normalcy and advanced or frank dementia. In this, there is a cognitive impairment, but not to the extent to impair the activities of daily living.
Now, after we understand what is dementia and what is memory loss and the types of dementia, can you also explain the symptoms of dementia?
Yeah. Coming to the symptoms of dementia, the most common symptom is forgetfulness. That is, patients forget. They keep forgetting things kept somewhere, like their mobile phones or their wallets or their spectacles, and they keep searching again and again for these things, and they forget recent events like what they have eaten for breakfast or lunch or dinner, and they even forget that they have eaten or not, and they keep asking again and again and also they forget whether they have taken medication or not. And these are very common symptoms, and later on they will have difficulty in finding ways. So they go to the nearby temple or a park, and they have difficulty finding their way back home, so they easily lose ways. And also within the house they can have confusion in recognizing the rooms inside the house. They have later on they develop difficulty in calculating and difficulty in handling their bank accounts or their bank checkbooks. And slowly they have difficulty in speaking. They have word finding deficits. Later on they'll develop difficulty in walking, gait disturbances. And also the presentation varies with the type of dementia. So if a patient has Alzheimer's, and they come with memory loss as the initial symptom, whereas a patient with vascular dementia, they present initially with executive dysfunction rather than memory loss. And also they have recurrent strokes, so they present with symptoms of stroke like limb weakness or aphasia or difficulty in speaking and other disturbances. And also in patients with other dementias like PSP, MSA, and CBD, they have Parkinsonian symptoms along with memory and cognitive dysfunction, like Parkinsonian features like bradykinesia, slowness of gait, tremors, falls, and all these disturbances can be seen in these patients. So, Dr. Shanmukhi, can you explain how to assess cognitive functions and what is neuropsychological evaluation in patients with dementia?
Okay. Dr. Jayasree, actually, first assessment of cognitive functions is with the screeners. And then neuropsychology battery is a very lengthy battery. Usually this assessment is mainly for seeing how much deficits and how much of cognitive loss is there or memory loss. As you know that Dr. Jayasree has just now explained the symptoms of dementia. All these symptoms are assessed in detail with neuropsychological batteries. First assessment tools are screeners. These screeners can be used for all the old age related people just to screen whether they come under mild MCA category or age related deficits or towards a dementia scenario. So these screeners commonly are Montreal Cognitive Assessment, Edinburgh Cognitive Assessment, Clinical Dementia Rating, Brief Rating of Dementia, Dementia Rating Scales. All these are, screeners, and also Mini Mental Status Examination, which is commonly used in the whole over the world. So these are used to just to know whether any elderly has any cognitive deficits, or is it normal cognitive deficits, or coming into a picture of mild cognitive impairment. So that is where it is very useful for the screeners on the holistic way of working. Once we recognize that the person is mild cognitive or some kind of cognitive deficits are seen, then we go on to evaluate neuropsychological functions. This is a detailed way of testing where you test right from attention skills and by doing some mental control tests like simple 100 minus 7 kind of a things to little more jargon of attentional skills. Now, coming to other kind of assessments which we do are reasoning abilities, abstract abilities, concept formation. These are all coming into executive functions and frontal lobe functions, where you see even motor functions and sequential motor testing and processing speed. So many people have processing speed problems where they become slow, like in Parkinsonism. So even these are assessed. Other parietal lobe functions are like visuospatial functions, visual constructional skills, or visual integration, or visual organizational skills. All this are assessed. And then coming to language and memory mainly, when it comes to language, we see the naming of the person, the naming objects and all, and repetition abilities, verbal comprehension, how he is and how he is able to answer, and fluency tests. Fluency, after doing these language tests, we understand that the person is having word finding difficulties or expressing problems, or forgetting names, or unable to name the objects. All these kind of abilities are easily known. Usually fluency tests are given, like for example, we give a category fluency by assessing 1 minute how many animals you can tell. So it's like that. And then memory functions. Memory will be like working memory functions as well as verbal and visual memory functions. We give some geometrical figures and ask them to retrieve. That can be immediate and or else after a delay of time. The same with giving some verbal words and retrieval or passage learning or something like that, so that we assess even the memory functions. So in detailed assessment tools are like, it's good to do a screener as well as a detailed neuropsychological deficits, because this will throw a lot of light on what kind of deficits are there in a patient, so that we pick up and we understand those deficits and try to minimize those deficits and work with the potentials which are already preserved with the patient. This will be more on intervention based, and also work, help on for the caregiver. Okay, Now that we understand some of the neuropsychological testing and assessment of a cognitive scenario, Dr. Jayasree, can you throw more light on the evaluation of a patient with the dementia, the lab tests required, and also the role of neuroimaging?
Yes, Dr. Shanmukhi. All patients presenting with memory disturbances, we need to evaluate them with a few tests, lab tests, including complete blood picture, vitamin B12 levels, and thyroid function tests. These are essential investigations in patients with suspected dementia. So, if we are suspecting a delirium as a cause of dementia, we need to evaluate further with the liver function tests, renal function tests, and sodium levels, electrolyte levels, and further they may need evaluation with ammonia, serum ammonia levels. And again, if we are suspecting as infection as a cause of this dementia, we need to evaluate them with serology like HIV profile and neurosyphilis in patients with high index of suspicion. And coming to neuroimaging, MRI imaging with MRI brain or CT is indicated in some patients, few patients with dementia when the onset is very sudden, acute onset, and also when the symptoms are progressing very fast with rapid progression. They may need imaging with MRI brain or a CT brain. And one more indication is a patient with dementia at an younger age, less than 60 years of age. We may have to evaluate with MRI brain with imaging of the brain. And also in patients with symptoms suggestive of stroke or subdural hematoma and other dementias like normal pressure hydrocephalus, we are suspecting non-degenerative causes. We need to definitely evaluate them with neuroimaging and other investigations like a CSF analysis. Is indicated in patients with suspected meningitis or encephalitis. We may have to check the organism with culture sensitivity reports and treat the patient accordingly. And specialized imaging tests like PET scan are indicated in patients with suspected autoimmune encephalitis.
Okay. Well, now, can you explain the treatments available for dementia?
Yes. Treatments, coming to the treatment aspects, all patients with newly diagnosed Alzheimer's dementia need to be started with medications like donepezil, rivastigmine, galantamine, memantine. These medications are known to improve the symptoms like cognitive abilities, neuropsychiatric symptoms, and activities of daily living. So, these are basically cholinesterase inhibitors which act by increasing the levels of acetylcholine in the brain. And there are few recently approved monoclonal antibodies which are available for the treatment of patients with early mild Alzheimer's dementia. Then again, the treatment also depends on the type of dementia and cause of dementia. In patients with vascular dementia and recurrent strokes, patients need to be treated adequately with good doses of antiplatelet medications like aspirin, clopidogrel, and statins like cholesterol lowering agents like atorvastatin and rosuvastatin. And also in these patients, risk factor modification is a very important aspect of the treatment. Like the risk factors like hypertension and diabetes need to be adequately controlled, and also cholesterol levels should be controlled adequately, and they should be treated for any underlying cardiovascular disorders. And now coming to other causes of dementia, like for example, the patients have severe vitamin B12 deficiency as a cause of dementia. They need to be treated with good doses of injectable vitamins with folic acid, vitamin B12 with folic acid. And patients sometimes have thyroid dysfunction. They need to be supplemented with thyroxine. And underlying other causes of dementias like hepatic encephalopathy, all these need to be addressed by consulting the concerned specialist. So, Dr. Shanmukhi, can you explain what is the role of non-pharmacological therapies in patients with the dementia?
There are varieties of non-pharmacological therapies that is mostly dealing with psychotherapies. These therapies help the patient in cognitive, psychological, and social scenarios. So these therapies are basically catered in a varieties of ways. Now, classically, when a dementia patient is with the depression or anxiety levels, cognitive behavior therapies are the first kind of order which we keep, which are very good and which will help the patient minimize their anxiety symptoms as well as depression. But there are other therapies like interpersonal therapy and family oriented therapies and problem solving therapies, which are individually catered. See, these therapies mostly are individual catered and specific to the individual and also to the family. Why? Because a dementia care is a holistic care. You have to handle the patient as well as the caregiver and the family also. So most of the therapies are depends on what kind of problem individually it is. So there is nothing like hard fast rule that we take only this therapy for everybody. We do individual catered therapies depending on the problem. For example, like depression and anxiety, CBTs. If there is some problem in replacing and difficulty that the elderly is showing and the family is unable to do, this is kind of a problem where you need to work on problem solving therapy kind of a thing. There are differences between the spouses in dementia cases, then it is interpersonal therapy which will be most useful for them. In cognitive therapies, we mostly work on cognitive, stimulation, and it's more related to the enjoyable activities which we schedule for them. And cognitive training. Cognitive training is mostly working on cognitive mnemonics, like simple memory clues or cues, taking help of digital aspects or the phone also. You give small stick pads or working with their memory loss in a more friendly way so that you keep some cues which they easily recognize and work on them. And also habitual learning means if you put a thing in one place, in the same place every day you keep, by habitual learning, a person need not have memory, but it's habitual. So they easily remember where they have kept their things and all. These are simple modifications and mnemonic use which we use for cognitive retraining. And also cognitive rehabilitation, where we go further in working with them in a daycare and also giving them activities. So these are some of the psychotherapies which are commonly used for them.
So, Dr. Shanmukhi, what are the common psychiatric and behavioral issues in patients with dementia and how to handle them?
Yeah, common psychiatric problems are depressions. Depression is the first thing which shows up, sometimes masking dementia also. So depression is first kind, and then anxieties. People even have delusional problems, psychosis. These are the common psychiatric problems, and also much more than that. And common behavioral things are like agitation, aggression, irritability, and incontinence, stereotyping, and vocalizations like screaming, talking something repeatedly, this perseveratory kind of problems, apathy, and many other behavioral issues which may be in day-to-day life faced. Now, coming to working with these kind of problems is mostly related to first kind is to get into psychotropic medication. And then before I have explained a variety of therapies which can be used individually, working with the individual as well as the family. And some certain environmental factors also usually precipitate these psychiatric and behavioral problems. So we work on the environmental factors and also emotion and cognitive therapies we give, or interventions which are easy, and they are multimodal interventions for addressing each of these issues. For example, swallowing problems, a speech therapist also works with. So there are multiple specialists who work with varieties of intervention on each of these patterns, depending on the behavioral and psychiatric problems. Here, I would like to add certain activities also, which work as stimulations. For example, sensory stimulants or cognitive stimulants are very essential for these dementia caregivers or dementia patients, where you can give them the tactile sensory aspects, like making them to knit or crochet, or massaging them, giving them a nice hair brush, or massaging their head, or massaging their pedicuring them or manicuring them. This kind of things soothe them, and also working on the sensory modalities of sound, where pleasant sounds or pleasant music, or a kind of music which they appreciate or they like, keeping that kind of stimulations, and involving them with Dow, playing Dow, some board games, gardening. Okay, all these activities one can try to keep them engaged and more enjoyable, and also have some jokes so that they are in a lighter mood and happy, and conversing with them and all. These are the few activities which also stimulate them.
Yeah. So, please let us know, is there any need for caregiver support, and what is the role of group therapies to help them out?
So, as you understand the term called caregiver, in the term itself we have giving, right? So, caregiver is somebody who is is a giver, and who is a pure expression of love towards them. So, this caregiver who is giving so much of love first need to understand that, by doing with the closed ones, they get very stressed out, because a dementia patient doesn't realize what he's going through, and sometimes they may have insight, but most of the time they don't have that much insight into their problem. So they'll be posing a lot of behavioral issues and psychiatric problems, as we understand the symptomology and you understand the types of dementia. So they pose with a lot of challenging aspects in life. So the caregiver's first attention should be first to accept the diagnosis of the patient. Okay, so you understand it's your father or a mother having the diagnosis, you first accept it. Okay, I understand now he is entered into dementia. After accepting, make adjustments and use the resources, whatever you have in the purview, to make the best utility of them. And I also suggest that caregiver should have a good knowledge of the symptoms, and get educated with them, and see this kind of talk shows to understand what kind of symptomology, what kind of problems they face, and how to handle each one of them. And whenever they get into crossroads, how to, when to go to the doctor, when to consult a consultant specialist, because there are a variety of people who are giving services for dementia care. So it's not only important to seek help for their problems, but also to seek help for themselves. So they should understand that they need to have some kind of ventilation and work with themselves. So taking care of themselves also becomes a greater challenge. So they need to know how much to engage and how much to retrieve back and work on themselves. So it's very important they keep some kind of social and psychological activities, which, other than stressing out, they're out of it. Or having some friends and social gatherings where you have opportunities to ventilate. Here, I would like to throw light on the role of group therapy, where it's very important if the caregivers have a group therapy sessions, where it is a big platform where, they speak about each other, and where the other person feels that they are understood well, because the same kind of problem others are facing, and day to day they are also, able to know what things are like. So they identify, they even understand, and they may exchange some kind of tips or some kind of things which, help the other person. By ventilating, even for the caregiver, it becomes lighter. That they are able to happily tell and do the best for their parents or their loved ones. So it's very important that caregivers should take care of themselves and do a good giving and the love towards their loved ones. Now that we understand, the caregiving and things like that, Dr. Jayasree, I would like to understand what are the issues of advanced dementia and, issues relating to dementia patients when it is progressed and advanced.
Yeah. So, advanced dementia refers to a state of severe, profound physical and cognitive disability. So, in this state, patients are unable to walk without assistance. They are unable to bathe without assistance. They are unable to dress without assistance. They are unable to eat without assistance. They have issues like urinary incontinence, fecal incontinence, and also they do not have any meaningful verbal communication. So, this advanced stage of dementia is a very difficult and very advanced stage to deal with the patients. And in this condition, they are prone to get complications like aspiration pneumonias, recurrent infections, especially of the urinary tract, urinary infections, and they can have bed sores, they can have septicemia, they can have recurrent hospital admissions, recurrent hospitalizations because of multiple issues like falls and fractures. And also they cannot maintain adequate calorie or intake, and leading further to weight loss issues. And all these are the challenges that we face in dealing with patients with advanced dementia. So one of the common things are eating issues, eating problems. They have dysphagia, and they have difficulty in chewing and swallowing the food. Along with that, in some patients, they are depressed and they just simply refuse to eat. So initially, better to give them conservative measures like changing the texture of the food, giving them more softer diets, and also we advise them to give their favorite foods, whatever is their favorite food can be offered. And after certain stage, they definitely need to go for a nasogastric tube feeding or PEG insertion. PEG is a percutaneous endoscopic gastrostomy tube. This tube feeding helps a patient to maintain the calorie intake, and also it maintains the nutrition, and it prolongs the life span of the patients with dementia, along with preventing risks such as aspiration pneumonia. And again, the other issue is they can have recurrent fevers and recurrent infections. So these recurrent infections need to be evaluated properly with investigations like culture sensitivity tests from the blood and urine, and identify the organism responsible and treat them accordingly with antibiotics. And patients who are having recurrent hospitalizations because of any complications like falls, hip fractures, or other fractures, they need to be managed in consultation with the concerned specialists. With proper advice and proper care and involvement of other specialists, patients with dementia can lead a comfortable and happy life for a significantly prolonged period of time. So thank you everyone.
Thank you
for giving
everyone.
this opportunity.
Thank you everyone.
Thank you.
Okay.
Yeah.
Okay.
Oh, okay.